My name is Diane Fabi King. I am a Senior Public Health Advisor for the National Health Service Corps, and I'm very happy to be here with you today and with our colleagues.
In a minute, we'll open up a poll on the right side of your screen just to get a feel for who's in the room today. So if you could submit your role and your organization, or if you're an NHSC participant, that would be great, and it'll help our speaker today. Speaking of, we're really excited to have Dr. Rosandra Daywalker here today to share her experiences and expertise with you all. Dr. Daywalker currently serves as Medical Director and Subject Matter Expert for WorkSteps, a comprehensive provider of occupational health services. She's a transformational leader in health, safety, and well-being. She holds double board certification in occupational environmental medicine and lifestyle medicine, and is currently a PhD candidate in public health. As a NIOSH Total Worker Health doctoral candidate at the Southwest Center for Occupational Environmental Health at the University of Texas, she's making a national impact as the first person in the country to hold this distinction. Dr. Daywalker serves in leadership roles for various organizations such as the American College of Occupational Environmental Medicine, the American College of Lifestyle Medicine, and the Association of Clinicians for the Underserved. She also serves as an inaugural advisory board member and founding member of the Society for Total Worker Health. Dr. Daywalker earned her undergraduate degree from the University of Miami, and she graduated with the highest honors from Morehouse School of Medicine. Her honors and achievements include the American College of Lifestyle Medicine HEAL Scholarship, ACOEM Resident Scholarship, Nathan Sostrin Unbeatable Mind Scholarship, Quality Improvement Research Award, Claude Organ Research Award, and several other academic service awards. She will also be receiving the Excellence in Health Equity Award from the Association of Clinicians for the Underserved at our upcoming conference in July. So congratulations, Dr. Daywalker. Dr. Daywalker drives change at the individual and systems level through trauma-informed, multidisciplinary approach to care, programming, and policy. Her current research focuses on the impact of total worker health and trauma-informed approaches on health and well-being. At the heart of Dr. Daywalker's work is her belief that genuine connections with others are the key to a fulfilling life and optimal well-being. In this mini-series on organizational resilience, we are following the framework offered by the National Academy of Medicine on the 6 domains of organizational, evidence-based, and promising practices for improving clinician well-being. Last week, during the first webinar, we looked at the organizational commitments and leadership assessments and structures needed to fully support large-scale efforts to support clinician wellness and organizational resilience. Today, we have Dr. Daywalker here to talk you all through the leadership roles and practices to monitor and bolster clinician wellness through intentional and inclusive decision-making. We'll also walk through assessing policies for redundancies and inefficiencies to eliminate the ones that no longer serve your organization and make more work for clinicians. Next week will be the final webinar in this mini-series, and we'll focus on efficiency in the work environment and clinician peer support. Our next mini-series, Leading During Public Health Crisis, will begin on June 7th. So before I hand the mic to Dr. Daywalker to get us started, I'd like to go over just a few housekeeping items. This webinar is being recorded, and a link to the recording will be emailed to you all within 2 days. The PowerPoint slides can be found on the webinar information page linked from your webinar invite from WebEx, but also on the webinar registration page. And I think we'll put the link to that in the chat now. And related documents and previously recorded webinars in this webinar series are also available on the webinar registration page. This is a 2-hour webinar. We will have time for Q&A at the end of the presentation, so please type any questions you have for Dr. Daywalker in the chat box on the right side of your screen. You might have to manually open that chat box, and to do that, just go in the bottom right corner of your WebEx screen, and there's a little chat icon that you can open up. There will be opportunities to engage with Dr. Daywalker during the presentation. We'll do some polling, ask for folks to type in the chat box, and you might also be able to raise your hand to speak, and we'll unmute you and we can have like an exchange. So if you do have a technical question though, please contact our colleague Josh, and we'll put his contact in the chat as well. To see closed captions, click on the CC icon in the bottom left corner of the webinar window. And I think that's it. So Dr. Daywalker, I'll hand the mic to you to begin our presentation. Thank you so much.
Thank you so much for that introduction. It is truly my pleasure and my honor to join you all today to discuss the second part of the Organizational Resilience series, which is regarding leadership and policy on the behalf of HRSA and the National Health Service Corps. And so today our learning objectives include that after participating in this session, you will be able to, one, discuss the significance of leadership when it comes to supporting organizational resilience. Two, explore how chief wellness officers can also serve to support organizational resilience. And three, identify opportunities to mitigate the impact of policies on clinician stress levels. And I'll offer a small disclaimer that these slides were created through collaboration, HRSA, the National Health Service Corps, and I have the pleasure of delivering the content in the form of the webinar and verbal discussion. So thank you again so much for this collaboration. So to start, let's level set and talk about what we mean for those who maybe were not at the first part one of this series, but what do we mean when we are referring to organizational resilience, right? We've heard the term resilience. We need to be more resilient, increase our resilience, ways to increase our resilience time and again. But usually that tends to be referring to resilience on the individual or personal level. So we're taking it a little bit differently and talking about the organizational level of resiliency, which is an organization's ability to continue to function in the face of adversity, and not simply surviving adversity, but the ability to adapt and transform to meet challenges. And that could be characterized by planned resilience, which is planning and preparing for future crises; adaptive resilience, adapting in the face of current chronic stresses and acute shocks; as well as everyday resilience, just being able to function through routine chronic stress that may come in day-to-day practice. And so, as Molly indicated, we drew from the National Academy of Medicine 6 domains of evidence-based and promising practices shown to increase clinician well-being. And so in the previous discussion, there was discussion about organizational commitment and workforce assessment. So today we're focusing specifically on leadership and policy. And then the following webinar will be about efficiency of the work environment and support. So let's start with leadership. And for some of us in the room, this might be a little bit controversial, but we want to say that appointing a chief wellness officer is a definite actionable step when we're discussing leadership's role in mitigating stress and in ensuring organizational resiliency. And then we'll also offer, as part of this discussion, how do we assess leadership qualities, not just for the top level or C-suite level leaders in our organizations, but for everyone throughout the organization. And also, how do we share leadership? How do we distribute leadership so that we can ensure that there is support at all levels of the organization and that we have equitable hands and equitable trust in the process. So let's start with appointing a chief wellness officer. And from someone who is a clinician, is a physician by training, and has many family members, including my own mom, who is a nurse, for example, I understand what it is to be on the front line, and I understand what it is to be a health worker. And there was a lot of talk, even prior to COVID, we started to talk a lot more about clinician, health worker well-being, mental health, and the different burdens and stresses that were essentially making what was otherwise a fulfilling role, a fulfilling career path, um, full of meaning, a calling for many, that was sort of turning it on its head and making it a source of severe chronic stress, and anxiety, depression, and even suicide. And a lot of people were looking for solutions. Okay. And I remember sort of the earlier iterations of the concept of the chief wellness officer coming to our organizations, coming to the healthcare space, because this was a concept that was already sort of existent in the corporate sort of industrial world. And so it was newer to medicine, which is really interesting, right? Considering what we do for a living. And it was met in some instances with almost cynicism. And many saw the chief wellness officer as just another administrator adding to the bloat of administrative burden, and probably counterproductive to burnout and all the things that we were saying were hurting us and keeping us from being the best we could be for our patients and for our society. But I think that with more time and maturity and evidence, and experience, that the chief wellness officer has really become an almost indispensable role. And it doesn't have to be called a chief wellness officer. There's a lot of different names that it can go by: chief health and well-being, chief well-being officer, no matter the title. But what's really important is the underlying framework by which this person or people approaches the role. And so their job would be to basically view all organizational decisions with a lens on well-being and serve as a thought partner in guiding important decisions being made by leadership. It's important to have somebody at those tables, at making those decisions or helping to make those decisions that are ultimately going to impact the well-being of the people who are in that organization. This person would also be responsible for developing the organizational well-being strategy and identifying and implementing well-being resources. So I think what happens now with the chief wellness officer, if deployed effectively and properly, the chief wellness officer signals both to everyone in the organization as well as to leadership that well-being, wellness, health, and safety are at the forefront of people's minds, are a key and integral concept in practice, and it isn't just lip service, but we are putting resources and support, true support, leadership, and sustainability behind this idea. And a very useful and important resource would be the American Medical Association's Steps Forward module. The links will be found or can be found in the chat by the end of this discussion, but essentially gives a step-by-step roadmap on how to establish a chief wellness officer position, and advice to the chief wellness officer, resources, and a roadmap essentially on how to be um, a successful officer in that capacity. So definitely recommend checking that out. So what are some examples of the day-to-day responsibilities that a chief wellness officer would be responsible for? Well, one would be measuring well-being, burnout, and professional fulfillment across the organization. Another would be measuring the efficiency of the practice environment and then using that information and that data to target, implement, and improve the practice environment. Develop an organization-wide action plan for actually improving clinician well-being, and determining what resources are necessary and advocating for those resources, and developing a business case and path to truly secure those resources. So in my line of business in total worker health, we have 5 defining elements. And the first one, intentionally, is leadership buy-in. And leadership buy-in is kind of like the soil in which you grow a garden. You need good soil, you need good sun, you need good water to ensure that your flowers will bloom. It's like trying to plant a seed in barren soil. It's not going to work, and it's probably not going to last. And so we bring in the chief wellness officer almost like our gardener to ensure that we have everything we need, and that whether it's coming from the top down or from our grassroots efforts up, that we can actually achieve these things and also build in longevity and sustainability so that these programs can be ongoing. So we have a poll. We're curious over here to know if your organization has a chief wellness officer or something similar, maybe a different name, but they essentially serve the same functions that I've been describing. And so the Slido poll feature will be available momentarily so that we can share what's going on in our respective organizations.
The poll is up and it should pop up on the right side of the screen where you see participants in the chat box.
For some reason.
If you can't see the poll, you could type in the chat your answer to the first poll. Does your organization have a chief wellness officer or similar position? Are you having issues seeing it, Dr. Daywalker?
Correct.
Okay, don't me read out the results for you?
You may need to.
Okay, so looks like 76% said no, they do not have a chief wellness officer or similar position. 12% said they do, and 12% said they're not sure. And looks like Jill in the chat is saying that they do.
All right. Oh, okay. Yes, especially you're more likely to see these at larger institutions. But so thank you for sharing, Jill. And if you feel up to it, would love if you would also share in the chat sort of, either what your experience has been with the CWO or what kinds of things they've been able to achieve or implement for your institution. And if you feel like it's been beneficial, and it's okay if you want to be as honest as you want to be. I don't have um, I'm not someone saying that you have to have this thing, and if you don't, and they're all perfect. But essentially, it's like a hammer. You can use a hammer to build a house, or you can use it to knock something over. And so it's really interesting to see what people's actual experiences have been in those who do have this position established. So yeah, so you're more likely to see it in larger institutions because they tend to have more, just more resources. But I think there's going to be a trend, or starting to be a trend, where you see it in smaller institutions as well. And we'll talk about that in a little bit, actually, in a case vignette towards the end of this discussion. So we have a second poll, and that is, who leads wellness efforts at your organization? And for many of you, or well, maybe not many of you, right? 12%. For 12% of you, that might be the CWO or some other well-being officer or champion. But if not, really interested to know, who is it that leads wellness efforts? Thank you for sharing, Jill. Jill says that of her experience with the chief wellness officer in her institution, she believes that they have been very helpful with many different departments. And so hopefully you'll have a chance at the end during Q&A to share just what that means so that others can have an idea of what that can mean in their institutions as well.
Dr. Daywalker, do you need me to read the
Yes,
data
please.
from this poll too? Okay, so it looks like 10% say they have a chief wellness officer or other similar position. 10% say that other C-suite leadership are leading wellness efforts. 14% say that they have a wellness committee. 27% said other could be interesting to hear those other groups or individuals are, and then 36% reporting no organization-wide wellness efforts currently exist.
Yeah, absolutely. I would also be really curious to know who the other C-suite leadership are, and or for the 20% that just said other in general, who those champions are in your institutions. Feel free to mention it in the chat as well.
We can also have folks come off mute if
Oh yeah, that'd be
have
great.
a conversation. So if anyone does want to talk about who's leading efforts at your organization, you can raise your hand at the bottom of the window. There's a little hand icon, and then we will call on you to unmute yourself, or we'll send you a request to unmute.
Marissa, I'm sorry if I mispronounced your name. Marissa says Director of Benefits, Compensation, and HRIS. Is that like a human resources related role? Yes. She says yes. Would anyone like to come off mute to maybe share their experience with either Chief Wellness Officer or any other similar sort of champion that's leading institutional-wide wellness efforts for our employees?
Amy in the chat also said other C-suite leadership is executive director at their organization, leading wellness efforts.
Wonderful. Executive Director. All right.
I don't think we have any hands raised, so.
Okay, sounds good. So moving on, but just the last I'll say about this for now is that I think it's essential to have one to model what we want to see. It's very hard, I think, and can even be counterproductive, counterintuitive, to state or say that we want our clinicians, we want our health workers, our health staff to be happy, to be healthy, to be resilient, but it isn't modeled through their supervisors or through executive leadership. You know, it's almost like a do as I say, but not as I do. And so I think it's very, very helpful to have someone, some champion within leadership who is setting that and demonstrating and modeling that behavior, right? So Aaron, thank you, Aaron said absolutely great point. It's almost like, you know, you've got to set the tone, and people will only buy in if they see that leadership also is bought in, because it's so hard to go against the grain, especially in our workplaces and with everything that's already going on and all the pressures that are constantly coming at us from so many different angles. So that's part of how you set a real culture that feels genuine, that people can buy into. And again, it doesn't have to be a chief wellness officer. You give it whatever name, but the framework still exists. And there's all these resources like the one that Molly posted in the chat to get you started. So thank you so much for sharing. So let's talk about assessing leadership qualities. So in a lot of our organizations, there are these regular or periodic staff satisfaction surveys where we get an opportunity to sort of voice what we are experiencing or what our needs might be in the organization from our standpoint. And so here are some example questions that could be added to a staff satisfaction survey that's already being deployed, or if you're thinking about revamping one that you have or starting one from scratch, that can maybe help you to understand what the general staff is sort of feeling, the sentiment or experiencing from a leadership perspective. And those questions are, for example, I have a clear understanding of the goals and objectives of the company. Senior management keeps employees informed of company matters. Company-wide communications are effective and useful. Senior management communicates the reasons for business decisions, and the company is doing what is necessary to compete effectively. A lot of these questions on this slide, for example, point to a concept that we know very well from probably several different sources, but one I'll cite specifically is maybe trauma-informed care. It's the idea that transparency helps to create a safe and empowering environment for people. It's just, again, it's if you remember when you were a kid and you asked your parents, well, why on some decision they made, and you had some parents who sat down, who said, because I said so. And then you had maybe some other parents who said, okay, let's talk about it, and had a mutually beneficial and transparent and empowering conversation. And it's the same concept. We want to know what's going on. There's something about the unknown that can make us anxious and fearful, especially when it comes to what's going on at work and when business decisions come down and we don't always understand what's going on. And maybe there's a really good, perfectly good, sound reasoning behind it, but the way we communicate it, or if we don't communicate it at all, can definitely affect how people receive or experience that business decision. And so I think that's what some of these questions here sort of speak to, is how we communicate and that leadership remains transparent of these different decisions and gives people a voice to actually also participate in the discussion. Here are some more examples. I can see a clear link between my work and the company's objectives. I believe feedback from this survey will be used to make improvements, right? Because what's the point of me giving my feedback or being vulnerable and transparent with leadership if it doesn't actually lead to any tangible change? Senior management models our values. I'm optimistic about the future of our organization, speaks to hope, optimism, and I have confidence in our senior management. One of my favorite sayings is that when people leave jobs, they don't leave because of the work, they leave because of other people. And sometimes it's the work, but a lot of times it's because of the people you work with. And there is actually a lot of evidence that talks about how your relationship with supervisors or other leadership can dramatically change your experience of your job. It can really bring balance or imbalance to the same exact experience. Um, and so having supportive supervisors or supportive leadership, and again, having confidence in your senior management can make a host of a difference, especially when it comes to facing those inevitable challenges and crises that come our way on a daily basis, or like we saw these last few years as a society. And I don't believe in reinventing the wheel. And apparently HRSA and NHSC doesn't either. And so again, they have provided a wonderful tool that you can deploy in your own organizations that you can use to assess the performance of individual supervisors. And that is the Mayo Clinic Leader Index. Mayo Clinic has been at the forefront of a lot of this research around clinician and health worker well-being, practice efficiency, you name it. And so this is just another one of the tools that they've developed through evidence-based tools that they've developed through um, levels of research and collaboration with leaders all over the country. And you can use this, for example, in your organization. It asks participants to rank statements about their supervisors on a Likert scale from strongly disagree to strongly agree. And some of the statements within there include that your supervisor holds career development conversations with me, empowers me to do my job, and encourages employees to suggest ideas for improvement. And this information isn't in order used collected in an effort to punish, poor supervisors, but rather to find opportunities for improvement, especially through dialogue and targeted training. Because a lot of times, sometimes supervisors end up in supervisory roles, but never actually had formal supervisor training. And being a supervisor is very different from being a super employee, right? Requires very different set of skills than maybe what the technical role called for. And so it just represents an opportunity again to have some dialogue, to do training, and to improve communication so that we can have strong supervisors and strong leaders in our organizations. And again, another wonderful resource that will be available in the chat, which comes from AMA Steps Forward module. And these modules are available to the public free of charge. I don't even believe you need a login to access them. And so is how to measure and assess leader behaviors to improve professional well-being. Are we ready for another poll? So this time we want to know, how does your organization assess supervisors? And this is an open-ended question, so feel free to share all the different ideas, or maybe it's not happening yet and that represents an opportunity for your institution. Thank you, Erin. Erin says they don't. So it sounds like this is something that we can take back to your institution and say, have we considered this? And you'd be surprised what kind of things may arise, and or you would be able to change, minute changes, small changes that'll lead to huge returns moving forward. And so I think the Slido is open, and Molly will share maybe in a minute what your thoughts are.
Yeah, so folks are typing in answers. It looks like someone mentioned an annual evaluation from their own supervisor. They used to do 360 reviews, surveys and evaluations, evaluation feedback, staff surveys, providing new manager training. And I think for you to see it, Dr. Daywalker, you would enter something and then I think you can see results. That might be the issue. Let's see. Other folks also mentioned 360 reviews, one-on-one, peer-to-peer. Someone said no true assessment of leadership skills. They do annual evaluations, but the existing tool is not meaningful or effective. So that's an interesting point. Someone else said they sent questionnaires to staff who are supervised by CMO, CFO, and president.
Say that one more time. And let me give you an update, Molly. I went to the apps and tried to open it, and it said only hosts can use this panel. I'm not sure.
Oh, okay. Then
that's okay.
We can make you a host, maybe. Okay, so the last thing you wanted me to repeat was that one organization sent questionnaires to staff who are supervised by CMO, CFO, and president. Another person said reportees assess supervisors annually, bi-yearly employee surveys, yearly or more frequently if needed, pulse surveys, yearly evaluations, biannual leadership training.
Good.
So lots of annual evaluations, it sounds like.
Yeah, that's really good. That's excellent. I'm glad to hear that. There's such robust activity around specifically this. That I think that is really hopeful, really hopeful and helpful. I had a couple of follow-up questions. I've heard of 360 reviews, but I want to hear from someone else, maybe Molly or someone from the group who might explain for those who might not be familiar what a 360 review is.
If anyone would like to speak, they can raise their hand and tell us about the 360 reviews at their organization, and we'll send a request to unmute. From my understanding, 360 reviews are when you have people sort of at all levels assessing the qualities that you present in your role. So like maybe the people you supervise are assessing you, the people who are like laterally in positions similar to you are assessing you, and then people above you as well. That's my understanding, but if anyone else would like to chime in the chat or come off mute.
Yeah, that is my understanding too. And you might have said this, but I think another part of it too can be self-review. So you also can give yourself your own performance appraisal, and I think it's useful, I guess it differs from sort of what a lot of us were used to in the past, which is mostly the supervisor doing the performance appraisal for those that they supervise, and no opportunity for that bi-directional or lateral sort of appraisal or review. So again, another sort of useful and interesting concept that we can all take back to our respective institutions.
And someone else just added peer reviews, 60 days, 6-month, and yearly evaluations, plus the 360 reviews. I was thinking too, 360 could maybe also include people from other departments assessing you.
Right. Wow. That one, those are the frequency of that one is very very encouraging. It gives, sometimes it's hard to know if you're making improvements um, when you only hear about things on a yearly basis. So I could see what the rationale is behind the one that has the ones that are, every 60 days and so on. Because then if you get some kind of feedback that gives you some information about opportunities for improvement, you can start to make those changes and get a pretty good turnaround and feedback to see if it's actually working, right? So that's amazing. Someone mentioned that while their institution does have some regular opportunities for feedback, it's not necessarily meaningful, and you don't have to say exactly what institution it is or etc. But feel free to share, or maybe privately you can share just what that means so that we can learn from that, how sometimes we can still be doing all the right things but miss the mark when it comes to actually making change, tangible change from it. So if you feel like sharing, you can come off mute, or if not, you can always send it to us sort of directly or anonymously so we can discuss it later.
And Stacy added in the chat an expanded definition of the 360 reviews, getting feedback from approximately 4 to 8 people, including an employee self-evaluation to provide a comprehensive look at an employee's efficiency, productivity, contributions, and work behavior. She also added that 360s are a good way to compare how one views themselves versus how others view them, because sometimes there's a disconnect.
I like that. I like that. Thank you. All right. So we had one more poll, which is, how does your organization assess executive leadership? And maybe it's going to overlap a little bit with the previous poll. Maybe you're using the same exact mechanism, but maybe there are some others. So feel free to drop those in the Slido app about how your organization assesses executive leadership. Is there even an opportunity or option? Does this data get shared back with you all? Do you see tangible change based on the data that comes back? Or are all of our executive leadership just doing amazing jobs and they just don't make mistakes and they always hit the mark? Maybe that's what's happening in the world, which is great. I'm excited to hear.
Sorry that you can't see the poll, Amy, but Amy is saying that their board assesses executive leadership.
Oh, interesting. Okay, that's a good way to do it. I wonder, does the general staff get any information into the board's assessment, or does it kind of stay under wraps?
I'll just add other responses in the Slido. Annual staff satisfaction surveys, monthly 1-question poll surveys.
Good.
Someone else said they're not sure yet because they're new and they've not
Okay.
seen executive leadership being evaluated other than their CEO, who was just assessed by the board. So another board assessing leadership. Another person not sure, they don't receive info when they provide feedback or submit concerns.
Can you say that one more time?
This person is not sure how executive leadership is assessed because they don't receive info when they provide feedback or submit concerns.
Okay.
someone else said each leader is assessed in their annual evaluation by the CEO. The CEO is assessed in annual evaluation by the board. CEO and board assess leadership. That was from someone else.
All right. Well, thank you. And, for me, my personal opinion here, my personal experience and opinion here says that executive leaders are still just people, just like the rest of us. And the true mark, I think, of leadership is, or one of the true marks is being able to open yourself up to feedback and in a vulnerable way, um, and understand, allow others to help you hold yourself accountable in your leadership, right? Um, Kind of goes back to, I think, what maybe Stacy mentioned, which is there's how we might view ourselves and how others might view us. And sometimes it connects and maybe sometimes it doesn't. And not because, we are bad people or we're malicious or it's intentional. It's just sometimes we can get a lot of information from through the eyes of a friend or through the eyes of our staff and employees, right? So having that opportunity, I think, is very helpful, again, in terms of longevity, sustainability of our efforts, and making sure that our leaders have our best interests in mind and continue to represent our interests to their best of their abilities. I see a hand raised.
That's me, Dr. Daywalker. I just
Hey.
wanted to mention there's a few notes in the Slido Q&A, which I was just alerted to. So Marissa is saying they don't evaluate senior leadership any differently, except the
Hmm.
CEO, but who is evaluated by the board. But another thing that they do is biweekly town hall chats led by
Love
the
it.
CEO. And every question asked is addressed, good, bad, or indifferent. And then Emily said, existing evaluation tools completed and administered strictly by the supervisor, no self-evaluation, no feedback from peers or other departments. I think this might be around supervisors. Tool is entirely subjective, nothing measurable. It's on our radar for improvement, but just haven't gotten there yet.
All right. Very understandable. And the biweekly town hall, that is very, we'll talk a little bit more about that, but that can be super helpful. Again, going back to transparency, empowering people, giving them a voice. And you mentioned something very specific. You said, essentially, they're going to answer whether it is, you know, flattering or unflattering, essentially. And that's bringing that level of fairness and consistency. People need to see and feel that. We can't shy away from the tough questions. We can't shy away from the tough decisions. And so I think the town hall is a really good opportunity to bring people together to have, again, have those conversations, and make those connections that might be otherwise lost through a series of memos, for example. So let's talk about distributing leadership. This is another key concept that HRSA and NHSC wanted to highlight, which is how we can empower each other, in order to sort of share the power of leadership, and sort of equivocate some of those power dynamics that sometimes can show up in organizations. And so this is the actually listen, act, develop, repeat model that was developed by the Mayo Clinic, which is supposed to be an effective means of establishing organization clinician relationships. And its implementation that they've seen has served to support efforts in mitigating burnout and improving physician satisfaction. Some organizations have appointed members of their own, of their clinical workforce to serve as wellness champions, who then are peers among clinicians that then promote engagement in the organization-wide well-being initiatives. So it kind of helps in terms of creating more of a peer support, having people who have the same shared work experience potentially, who can then speak to those systems and those changes, in a way that reflects what's actually happening in everyday practice. And so when you adapt or use the listen, act, develop, repeat model, you basically start, again, listening. We have two ears and one mouth for a reason. And you actively seek to identify and understand what the specific pain points are or burnout drivers are. It doesn't help to assume, because you know the famous saying, what happens to you and me, we don't always get it right. And then act, taking that information and empowering physicians, clinicians to develop and implement solutions to address those top burnout drivers in the work area, develop develop physician leaders in the context of the improvement of work, and then repeat. This is meant to be a continuous cycle of performance improvement. Cyclical. Sometimes you find, okay, once we've addressed one issue and improved it, another one may may appear in its place or be unearthed, or now we're working our way down our priorities. Or the same issue may have different iterations depending on the context and timing of things going on in society or in the workforce. And so this is just one model that you can use, and we have the source there, and will be available um, if you want more information on what that looks like in true practice. Okay. Again, this is a dialogue, it's a conversation. So I want to hear from you. How are clinicians engaged in leading well-being initiatives at your organization? Do they have a voice? Do they have time to have a voice? Is another question for another day. But how are you able to contribute, or your peers, to these initiatives? Are you at the table helping to shape and design them? Are they asking your feedback on what you actually need or want, and what those pain points are? Are things made in the system so that you actually have time to participate in initiatives? I would love to hear.
It looks like we have some people typing, but I don't see any responses quite yet.
Okay.
So someone said clinicians are not being engaged in leading well-being initiatives.
Clinicians are not engaged. Okay.
See lots of people typing, just waiting. Okay, we have a program where clinicians can be quote unquote wellness champions. We've held focus groups by department.
Okay.
Very few clinicians lead any initiatives, but there are a handful who contribute when approached for feedback. Someone else said clinicians are not engaged.
Mm-hmm.
I think we have some more answers coming. Someone else said we had a forum last week to
Okay.
ask questions. They asked about starting a well-being program, and they said, oops, they've done focus groups, but it didn't go well.
Mm-hmm.
Another person said their pediatrician has 4 hours of admin time a week to be part of wellness, efficiency, process improvement, etc.
Wow.
It looks like a couple more people might be submitting something in a minute.
I'll let them keep thinking and typing on that. Just hearing a lot of really good feedback. And when I say good feedback, I don't mean it's all flattering, but that I'm really enjoying the engagement, and that people feel safe and empowered to contribute what their real experience is, right? Because yeah, we're talking about well-being, we're talking about wellness, but it's not all roses, right? And again, people can be super well-intentioned and want the best for our organizations and the people in it, but sometimes it's hard to get it right. And that's why, you know, we're having these conversations. So one of the things I noticed was the kudos to the group that, you know, just had their forum recently. Multiple people mentioned that clinicians are not engaged. And so I'm wondering, you know, it's probably a combination of factors. Is it that, you know, clinicians are just sort of left out of the equation? Is it that clinicians are too busy or not given enough time and space to actually participate? Um, or, are they declining because of maybe some level of cynicism? I'm very curious to know. But again, it goes back to, having people have a seat at the table from the beginning, where we've learned a lot from our mistakes in healthcare. One of them being, taking a very patriarchal stance and telling people what they want and what they need, as opposed to asking them what they want and need. Again, from my world and total worker health, one of the five defining elements is to engage the workers themselves. From the beginning, comes from the world of public health, community-based participatory research, which many of you are probably very familiar with, especially my friends at HRSA and the NHSC. But not going into communities, not going into populations, not going into workspaces and telling people what we think they need or want, but truly listening, and letting people tell us. And maybe it doesn't always feel good, but at least it's the truth, and that's where real healing starts. So um, the 4 hour admin time, I love that. And we'll get into that in a second in the next section, which is about policies. Molly, anything else going on in the Slido?
Yep, one more comment from someone who leads team communication trainings, and they have a clinical co-facilitator who partners with that person to lead the workshop. And those folks were nominated by their departments and given a stipend for participating.
Nice. That's awesome, right? Um, that makes it makes a world of a difference. And I'll also say that another thing I constantly say to my loved ones, to the other Dr. Day Walker, who maybe did a talk recently, is that more is not always better. Sometimes it isn't about adding more programs or adding another step challenge or adding another webinar. It could be looking at what you're already doing and streamlining or optimizing it, or actually combining or integrating it. Sometimes we duplicate and triplicate and quadruplicate programs, especially in a lot of large organizations where there's multiple people or departments working on very similar ends, and we can sort of bring each other to the same table and bring our resources together and our personnel to make our programs or initiatives that much more powerful and streamlined. And sometimes it's about taking away things, right? Well-being in the organization, sometimes it's some of the things that we're already doing that are taking away from our wellness, and requires us to remove some of that, some of those hazards, if you will, so that we can thrive. All right, moving on. So we're going to switch gears now and talk about policies. So again, I come from my world of study and research comes from looking at things from a systems level. Like I said, I was on the front lines, and I remember those days of especially residency, my first residency training, where it felt like a lot of us were in a burning building, and we were being told that the part of the problem is that we're just not resilient enough. And if we did more yoga and we took more walks and we slept more, that we would be more resilient. And I love sleep and I love yoga and I love taking my walks. But at that time and in that environment and the way that we functioned, that was impossible. It's impossible to do any of that stuff. So I came to this world, in this side of things, occupational and environmental medicine, because I wanted to see how I could make a difference from a systems level perspective through practice, through policy, and through procedure. Because it felt like when I was in that burning building, when we were in that burning building, people were telling us to just drink more water. And that does nothing for the building that is on fire. So, of course, that's why we're talking about leadership, and that's why we're talking about policies, and we're talking about organizational resilience, because we have to fix the environment and the system. At the same time that we encourage personal resilience and personal health, we also have to make sure that our organizations are set up for success. So let's talk policies. As we know, again, the healthcare system is a very, very special place. It's not the same as working, in a steel mill or working, in tech. It's very different, and we have a lot of regulations to ensure health, safety, and privacy of patients. And sometimes these regulatory demands and reporting requirements end up having unintended negative impacts on our time and our ability to provide what we know to be quality patient-centered care. In addition, how many of us have found just overly restrictive or even duplicated policies that end up creating stress for us, um, and burnout, especially when it comes to dun 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 EHR, right? So a resilient organization knows this, sees this, and addresses it. So it takes, developing some innovative solutions, so that yes, we meet compliance, we meet regulation, we meet reporting requirements and all of that. But at the same time, we don't cause our clinicians to completely sacrifice what it really means to give direct patient care. So this could mean identifying policies that might be interpreted too rigidly, or delegating documentation and other non-clinical tasks to support staff in an effort to, again, leave that room open so that people can do the jobs to the best of their abilities, and thrive in their respective roles. So again, that could be identifying policies and procedures that are duplicated and no longer necessary, right? Maybe this policy was created 30, 40 years ago when we had um, certain Medicaid rules in place, but now things are different. So we have to continuously revisit those policies that we have in place to make sure that they're up to date and that they're still relevant, right? How many times have were you doing some task and then someone asked you to do some other task on top of it, again, just purely administrative, and you were like, why am I having to do this? What is the point of this? Maybe there's a good reason, but often turns out that it is a vestige of an old policy or something else in society or in the workplace that no longer serves relevancy because things have evolved and things are going to continue to evolve. I mean, when you're looking at what's going on with technology, with AI, we're going to have to rewrite a lot of things in terms of how we practice healthcare. So again, taking some time to revisit our policies and make sure that they are coming from a human-centered place, and that they still make sense. So, can policies be simplified? And we have some examples here of policies and processes that often are overcomplicated that actually can be streamlined. For example, online patient reviews or preventive or wellness evaluation and management services, EHR documentation, verbal orders, or ancillary and or staff patient documentation. Um, and so, again, AMA has provided a wonderful resource maybe to help clear up some of those misunderstandings and myths that a lot of us probably were um, indoctrinated with or just haven't had the time to update, in sort of debunking those regulatory myths and understanding what's truly required and what's truly required for compliance and what is just maybe a vestige of an old requirement that no longer is relevant. So probably be really interesting for a lot of us to go in there and get educated and start dialogue within our own institutions to see, oh, yeah, we have this thing and it served its purpose, but now things are different, and here's the most up to date information. And that is provided in the chat. Thank you, Molly. Again, just following up on that idea of identifying policies and procedures that are duplicative or no longer necessary. Again, with EHR, right? EHR is uh, it's not death by a thousand cuts, it's death by a thousand clicks, right? So minimizing alerts, for example, simplifying login. I know that we have to keep our login safe and secure, but I've logged into systems sometimes where I type in a password and then I've got to look at my phone and then I've got to get another password and then I come back and then I go to another screen. And by that time I'm exhausted and I want to go take a nap. You know, that's how it feels sometimes. And so figuring out again how to appropriately leverage technology to ensure safety and security, extending the time before auto logout. Again, it's the little things that end up adding up to a lot of work, but sometimes um, what is meant for safety and security can end up creating undue burden on people who are trying to get a lot done with very few resources. Similarly to password related burdens. So, you know, just again, another opportunity or opportunities that we might look at that could really, you know, small things that could really have a huge impact on the global experience that people have. So I would love to hear one thing or one time that your organization did to streamline the implementation of a policy. So maybe your organization is has already worked out or is in the process of working out the EHR, electronic health record burden, or maybe there was something else that they did. And I would love to hear, and I think your colleagues would love to hear what's going on in your institutions.
The Slido poll is open on the right side of the screen. If you can't see it, again, you can post in the chat or feel free to raise your hand, the little hand icon at the bottom of the screen.
And you can also share some other ideas, you know, maybe policies that were put in place, sort of like the one that was mentioned earlier that the clinician has 4 hours per week of administrative time, which then opens up a lot of possibilities, right? That, and I think there's something too about, you know, understanding the amount of administrative work that does go into this role and giving people that support and empowerment just makes people feel appreciated and seen and understood, and it makes a world of a difference. And also, of course, it's incredibly it can be counterintuitive to encourage people to participate in activities that they can't access, right? If you are constantly engaged in direct care or other tasks that just make it impossible for you to peel away and participate in that meeting or that opportunity for connection or that wellness committee, um, it makes a difference. And so, what kind of policies? I'm really interested to hear what kind of policies maybe were removed, were improved, were rewritten, or introduced to ensure that people have access or change the experience of people.
So we have a few comments. Someone said they have a committee devoted to review and approve policies. Another person said for bigger policy changes, they've done a staged rollout, testing it at one site before implementing it at all 3 locations so they can figure out hiccups on a smaller scale.
Nice.
And then someone else said we had an interprofessional meeting and the policy was expedited and sent via email to start immediately.
Look at that. Look at that. Well, that's awesome. That is a new one for me. I really like the idea of, basically piloting new policies in a stepwise fashion because, inevitably there might be some hiccups. Better to experience it on a smaller scale than on a large scale. and then be able to deploy it fully. So that's excellent. Having the committee to review, again, given that teamwork aspect and multiple perspectives is always helpful, especially if you have good diversity of people and experiences and perspectives on that committee. Because we might be looking at one policy and thinking, yeah, okay, that makes sense. Um, but then from our lens or our position of privilege, we sort of miss how it might be disproportionately affecting someone else who isn't in our position, doesn't have our sort of level of access or privilege. So that is excellent.
There's one more comment. For substantial changes or additions, they push policies to staff via their HRIS, which people log into daily so that they don't have to waste time looking for things or worrying about forgetting about them.
You bring up a wonderful point, right? A lot of people, maybe not in this conversation or maybe in this conversation, I'll raise my hand, in the past, who had time to read the policy book, right? Especially when you're a new hire and you've got all the different modules you've got to complete. And if, it's just a lot of work to do and you're trying to get accustomed. I mean, a lot of people just see that policy book and they hit that check box and say, yes, I got it. There's a lot of helpful information in there because a lot of people took a lot of time and effort to put it together. And so making it so easily accessible, and so people, don't have to expend so much energy just trying to find it, super helpful. Just trying to find that information or new changes, very helpful, very helpful. All right. Another idea that the National Academy of Medicine put forth in terms of what we're talking about and organizational resilience and leadership and policies is delegating reporting and other non-clinical tasks to support staff. And part of that means that going to need to hire those support staff, such as scribes, medical assistants. It's unsustainable to ask people to wear so many different hats and to play so many different roles with not enough resources and healthcare, not to sound trite, but it really is a team sport. We don't do it alone, we can't do it alone. And what's helpful is not that we're punting unfavorable work onto our teammates, but more so that we are sharing in the tasks appropriately and that all of us are getting to work at appropriate levels of our scope, of our expertise, and of our skill, that we're not being uh, asked to do things that are too high within our levels of expertise or too low, and vice versa. So, one way that healthcare organizations are doing that is by integrating scribes and medical assistants to their care teams, which then maximizes the time that clinicians can spend on direct patient care, which has great implications on the clinician's own self well-being as well as the patient's experience, right? Big trope that we've seen in the last several years. My clinician, right? Usually my doctor comes in, is with me. I've waited for 1 hour. My doctor comes in, sits with me for 5 minutes, and runs back out. The whole time they're looking at the computer. Do you think that those clinicians, that doctor, woke up that morning and said, I'm going to go and talk to my patients for 5 minutes at a time, look at a computer or the screen the whole time, and then run out so that they can have a bad experience? Do you think that when they were training to become physicians, that that's what they had to look forward to? They said, this is how I'm going to take care of patients? Absolutely not. It's more likely than not a reflection of the systems that are in place and the administrative burden that's in place. So how do we correct for that? How do we reverse this? We make sure that we delegate and we share in these tasks and look at it for what it really is, in terms of delivering healthcare. There have been studies that looked at the return on investment for scribes. Um, and while it is mixed and dependent on a number of variables, including how primary care providers, for example, are paid, That's sort of where they're sitting now. But I think anecdotally, a lot of people are seeing things that can't necessarily be measured by dollars and cents because that's what return on investment is. And so other ways to sort of look at it might be through more about looking at it as the value of investment. So things that can't be measured in dollars and cents, such as improved health outcomes, such as patient satisfaction, such as reduced turnover, which ultimately can be, you probably can calculate the dollars and cents because I get it. Our CFOs need to see that it makes fiscal sense. Um, but that's another way to sort of think of it is the value of investment and what it means, again, when you're talking about human-centered and patient-centered, the decisions that we can make. And with that being said, it is time for a case study. Let's see, where are we right now? It is 2:12. We have about 45 minutes left, Molly. Is that correct?
Yes, and it's okay if we end before the hour, but you've got plenty of time.
Okay. Um, I just wanted to give people like a 30-second break, if that's okay.
Of course, no problem.
Thanks. So you can use your 30-second break. You can close your eyes and breathe. Stand up and stretch, which is what I'm gonna do. Look outside, and if you have a window, look outside and admire outdoors. Or check your text messages or TikTok, I don't care. All right, moving along. So, we talked about a lot of concepts. We talked about a lot of theory. We talked about a lot of research. But let's talk about how you can actually do it and truly deploy it. So this case study actually comes from Access Health Community Health Center, and it was brought to us by Dr. Marquand Daywalker, who's, oh, my video is off. Let me fix that. All right. So this case study comes to us from Access Health Community Health Center by Dr. Marquand Daywalker. And yes, we are related. I live with him. That is my husband. And he is the Chief Health Equity and Wellness Officer. And he also was an NHSC Students to Service Scholar who actually completed his service commitment and decided to continue to stay in the service because he loved it that much. So let's talk about what was going on. I'm very intimately familiar with this story because I actually helped him with a lot of these projects as a consultant, help the center as they were deploying a lot of this. So let's talk about it. Basically, a few months after starting his first attending job as a family medicine physician at Access Health, this really great opportunity to be on the team of champions leading their trauma-informed care organizational transformation came to him, and couldn't pass up the opportunity. Sounded like an excellent opportunity. For those of you who aren't familiar, trauma-informed care is a concept that comes from um, Substance Abuse and Mental Health Services Administration, and essentially um, addresses and identifies that trauma, speaking of events that are potentially traumatic, um, this experience is a lot more widespread than we thought before. And it's based in the ACEs study, Average Childhood Experiences study, of, I think, the early 2000s that looked at the relationship between those traumatic experiences, such as experiencing poverty, such as substance abuse or living with somebody who abused substances, such as being institutionalized, etc., and how that affected people on a long-term basis. And as you know, these, especially if you've had more than one experience that has had long-term effects on you, that there are substantial effects in the realm of health, mental health, physical health, of course, social, educational, career, economic, and more that this can have on people. And not only that, but people can have secondary and vicarious effects of trauma, right? Especially those of us who work in people facing, people centered fields, or the health services, human services fields, right? Such as education and, of course, healthcare. We're exposed on a near daily basis, not only to our own stressors, but also to the stressors of our coworkers, to the stressors of our patients, especially if we work in communities that are more vulnerable or historically marginalized, as many of us do, who are in the NHSC and HRSA network. So um, they got the opportunity to be part of a cohort a few years ago, just before COVID-19. This was maybe September, and the first lockdown happened in March. And they were already sort of in the early stages of implementing or going through their transformation when we went into the first lockdown and COVID-19 cases started to rise, and people, I mean, it was clear that this was having an impact on people's well-being at the center. And so they were faced with a choice, which was, put the tick transformation on hold because, hey, like, there's a lot going on in our clinics. There's a lot going on in our communities. We just don't have the bandwidth, right? And this is just another thing that we would be asking people to do that might potentially stress them out more unnecessarily. And that was choice A, put it on hold. But choice B, Dr. Daywalker said, actually, I think this is the best time to do this. Let's push forward and leverage this, because I think that we need this to help people through this time. And he was right. So they actually continued the process, started applying the principles of trauma-informed care in throughout their employee health and well-being initiatives. So this time they sort of flipped it, because typically TIC is implemented for patient benefit, right? It's more about how do we provide services to patients, or in other services, they might refer to them as clients. How do we provide services to patients in a way that is trauma informed, that employs the pillars of safety, of trust, peer support, empowerment, voice choice collaboration, and um, gender, racial, and cultural context. But this time, this organization said, actually, let's use this to take care of our own, which will have the likely have the secondary effect of helping the patients anyway. But we need to take care of our staff, okay? So that we can lessen the effects of COVID-19 and everything that came with it. And so the Texas Association of Community Health Centers is the local PCA that implemented and introduced the study. Oh, there it is. Let's see, did I get all of them right? Yes. Safety, trust, choice, empowerment, collaboration, respect. And just for a little bit more background, there are the 4 R's of trauma-informed care. And those R's include realizing the widespread existence of psychological trauma in our society, recognizing the effects of trauma. For example, in the past, you might have heard someone, make a comment about a patient and say, that person is non-compliant, but sometimes things that have to do with previous trauma or ongoing trauma may manifest as what someone might see as non-compliance. And so understanding that Sometimes it's about what happened to people, not what's wrong with them that you're witnessing. And then responding. Then third R is responding appropriately to those effects. And the final R is to avoid re-traumatizing people, because what tends to happen to already traumatized people or people with history of trauma is that the services that they seek out to help them can inadvertently re-traumatize them in different ways. And they're often the people that need these services the most, but aren't necessarily supported or feel safe and empowered, and thus may end up counterproductively avoiding them altogether. So Access Health worked to align their policies, practices, and procedures with the principles of trauma-informed care, and all departments at the organization received training using a train the trainer approach. So it wasn't just for the clinicians. This was for everybody. They used the why before Dr. Vivek Murthy defined it in his report, but basically health workers, meaning everybody within the center, from the people who greeted you at the front desk to the people who made sure that the clinic was a safe and clean and healthy environment. And so it didn't matter who you were in that organization, you had access to this information, to this training, and they deployed champions within all of the departments so that this could, again, have longevity and sustainability. In addition, this was something else that he had wanted to, that he also sort of incorporated or saw incorporated, which was that looked at organizational factors that were driving burnout, such as values mismatch, perceived lack of control, workload, lack of fairness, poor relationships, and lack of recognition and reward. And essentially matched the different activities that we deployed to each one. So, for example, when it came to values mismatch, right? You tell me I'm a healthcare hero on one hand, but it doesn't feel like it when I come to work. Um, was sort of addressed through um, leadership buy-in, making sure that everybody, starting with the CEO, was on board, which means we get the engagement and the budget we need to do what we need to do, as well as the creation of the administrative position. At that time was director of well-being, which ended up being him. And so having somebody with that focus who also had a direct line to leadership to say, this is what's going on the ground. Um, Lack of control, perceived lack of control, again, a hallmark of chronic stress and or potential trauma is feeling like you have no control, feeling powerless in a situation. Okay. And so one way they sort of addressed that was creating an anonymous feedback tool. Really, it was a digital or an online suggestion box, sort of like a tell me how I'm doing, but online and anonymous for people who maybe didn't want to be identified, but still wanted to have their voice heard. And that information didn't just collect dust in a box somewhere, it went directly to the director of well-being and directly to the CEO. So again, sort of leveling that line of communication. Instead of having multiple layers, it has to go to this person first, then that person, and maybe it makes it to the CEO. Now the CEO is hearing directly from the people what's really going on. Of course, workload, right? And so they made changes, adapted. We're talking about organizational resilience, adapted by improving operational processes, asking people, what do we need to fix or change, maybe removing certain requirements temporarily to give people the space and bandwidth to take care of the most pressing and urgent needs in the early pandemic. Lack of fairness, again, when they received feedback regarding what was going on with supervisors, this was an opportunity for them to have dialogue and train. And some people unfortunately weren't with the organization anymore after that by choice, because maybe they weren't ready to align with sort of this more equitable um, uh, interaction with their direct supervisees. And that's real. It's not always roses, but sometimes we have to make tough decisions if it means that we're going to be better as an organization. Um, what else? Poor relationships. Again, these concepts come from a book that he was reading, The Burnout Epidemic, by Moss. But poor relationships, or in our case, early COVID was isolation, a lot of isolation. Either because we were afraid that, I mean, it really meant life or death at one point, right? Um, Still does. But also, just time constraints, a lot of different factors. But the point was that we understood early on that people needed each other to get through this. And so they implemented a buddy system that they were able to use, that essentially paired people with people from other departments, which was very intentional, so that you could form some relationship with somebody you might not necessarily ever get to interact with otherwise. And you could keep each other, check in with each other. You could encourage each other to participate in whatever well-being initiatives were happening, or in your own personal wellness initiatives. And it just kept people connected, and addressed that isolation that we were all going through. And then lack of recognition and reward, of course. There was this hero building campaign. So HERO is an acronym that comes from a positive psychology field, actually, Dr. Fred Luthans, who talks about positive psychological capital. And HERO actually stands for hope, efficacy, like self-efficacy, resilience, and optimism. And so they use those concepts to frame their messaging, to anchor their interventions. So when they were doing, different wellness initiatives, don't ask me exactly which ones, but the point was to increase happiness, to increase psychological capital and well-being, and really just support the people. And of course, it has the byproduct of helping with performance and productivity. Who knew, right? Who knew if you support people and you treat them well, then they will perform better. So again, just sort of reiterating those strategies for success, just trying to tie it all in together. Um, what we were talking about earlier with what happened at Access Health, they got the leadership buy-in, which gave them the resources they needed, empowering staff voices. They went directly to the people and asked, what do you need? What do you want? How's it going? And on a regular basis. So they did that through both that online suggestion box or survey tool. They also had a few actual organizational wide surveys or questionnaires that went out, that I helped them to create. And they also had regular town halls. They had regular town halls, and that was their way of keeping everybody abreast of what was going on a regular basis. So, for example, right, especially in the early parts of COVID, there was just so much uncertainty, so many unknowns. And so this was a way to get the information directly to people, and people could ask their questions or give their feedback in real time, and say, either, this is what's going on and this is why we're implementing this, or this is what new resources that are available to you that maybe weren't available before or you didn't know about. um, you know, and people then in real time again could ask what is going on, or I don't agree with this, or this is great, thank you so much. And again, it's all about the conversation, it's all about the dialogue. And then of course, sometimes you can't do it all. we don't we don't have unlimited funds or time or people, and so it's okay to utilize external resources to get the training and technical assistance you need, especially from your local PCA, Primary Care Association. They're always there for you, I think. They're there for you. They have resources and ties to other community resources that might really benefit your staff. And so at the end of all this, or throughout this, we saw something really interesting happen, right? In the rest of the world, there was nothing in the news but how workers were leaving the workforce in droves. Healthcare workers were leaving the healthcare workforce in droves, that well-being across the board, worker well-being was going down, everybody it was burnout was going up, etc. But weirdly, in this time period, Access Health actually saw improvements in their staff between, I want to say, August of 2020, right? So this is 5 months into the pandemic, and 1 year later, when they did their annual checkpoint, overall well-being went up for clinicians, compassion fatigue went down, burnout went down, gratitude went up, positive supervisor relationships went up, and feeling that the organization listened and addressed worker concerns went up. And so, all that to say is that you're not alone. There are plenty of resources out there. You don't have to reinvent the wheel. You've got us, you've got HRSA, you've got NHSC, you've got your local PCA, you've got your local universities who are always looking to help. You've got NIOSH and Total Worker Health. You've got it all. And it's not a matter of, you don't have to do everything, but know that you can start somewhere and do something. Um, and we're here to support you. So, with that being said, I would love, love, love to open it up to questions, comments, etc. Thank you so much for your engagement and time.
Thank you so much, Dr. Daywalker. That was a really detailed, thorough, really engaging presentation. Thank you again. So yeah, we do have some time for questions from attendees. And please post any questions you have for Dr. Daywalker in the chat, or you can request to be unmuted by raising your hand at the little hand icon at the bottom right hand of the screen.
So I'm going to stop sharing my screen. Is that
Yeah.
okay?
Uh-huh.
I know that was a lot.
Yeah. One thing that came up for me, and this is just sort of like a personal anecdote, my sister is a family nurse practitioner, and I was talking to her about these interventions that can be used to help with burnout and administrative tasks. And I mentioned the scribes to her, and she said she sort of had some issues with that because she preferred the way she takes notes in the medical records. And I wonder if anyone has heard of sort of those concerns from clinicians with encountering like that kind of intervention.
I'll kick it off. I have not personally used a scribe, but I've seen different ways that other people implement that. So, for example, I just went to see my own family doc yesterday, and she uses an online, like someone digitally is on her computer scribing. I've also seen several years ago in my first training where they had an in-person scribe, and that person was with multiple folks, different clinics, but that was their job, and so they really got to know um, the ins and outs of the business, so to speak, or the department, because, for example, I was training in ENT at the time, head and neck surgery, and it's a very niche specialty, and with very, 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 what's the word? Esoteric information that you don't just hear in everyday talk. So I think one of what I learned from both of those is basically that it takes time to get someone acclimated and truly, understanding your style and preferences. But it's just a matter of time and training, right? Like anything, and it's a trade-off, right? It's kind of like that saying, give me, what is it? Somebody knows it in here. I always mess it up, but basically give me the something to know what's in my control and what isn't, and the wisdom to know the difference is like, you know, what are your priorities? What matters most to you? Is the note taking adequate, sufficient, and appropriate? then does the stylistics truly matter? You can always go back and adjust things. Or if that is more important to you, that it is exactly in your voice, then that's just the trade-off you have to be willing to make, in terms of your time and completing those notes. Ooh,
Yeah,
we've
thank
got
you for
some
that.
feedback in the
Oh, you can
chat.
see it? Okay. I'll let you read those out.
Okay, let's see. We got some good ones. We have some providers who request that they're assigned a scribe in their contract. We've got people saying, I'm not coming to work for you unless I've got a scribe." um, For a former employee that I worked with, I implemented a very large scribe program. Even the providers who were the most specific about their notes came around to loving utilizing a scribe. If they're willing to work with a scribe and give feedback, they are great at learning and adjusting to make the notes how the provider wants them. Yeah. Yep. And really great information. Oh, I'll come back to that. I'll come back to Emily. I had a provider tell me that I literally saved his marriage because he was now able to go home at the end of the day and not spend hours doing notes, which allowed more family time. So I agree. It's sometimes too when it comes to people like those of us. I used to be like that, really particular about my notes. I had to let that go because I was spending hours on hours doing these, and it's yeah. So I see that. Um, Really great. So Emily Thacker says, really great information. And the case study was helpful to demonstrate that these types of initiatives can really work if thoughtfully designed and implemented. I think it is a matter of being mindful and prioritization of work, to focus on the things that will move the organization forward as opposed to the day-to-day stuff that tends to just maintain the status quo. I love it. This is like a quote that should be at the front of a book on this stuff. Exactly. Exactly. And I love, like you said, mindfulness, intentionality, you may call it. But remembering what you're there for, the real vision, the real mission, um, and eliminating the fat. But yeah, thank you so much. And what I really want to emphasize is that the things that they did at Access Health, just remember, Access Health isn't your favorite multinational corporation that has billions of dollars profit every year, right? Um, Access Health is an FQHC. It's a federally qualified health center. It's a community health center. Um, and so they made and found a way to demonstrate that they really prioritize and care about the health worker experience, right? You can only push people so far, and I don't know why you would want to. When you take care of people, then we develop the strength and bandwidth and resilience to take care of each other. That organizational resilience piece directly, it mutually reinforces the personal resilience piece and vice versa. So, it's just put up the money now or another term and reap your benefits later.
Thanks, Dr. Daywalker. I do have another question. How do you balance keeping clinicians engaged in wellness efforts, but not adding to their workload?
Well, let me give a chance for someone else to speak. Um, and if no one pops up, I will take that question. All right, I'll take it. So again, I think the first part of it is listening. Um, is asking people what they actually want and need. It reminds me of I was talking to a really good friend of mine who'd had something really heartbreaking happen to her recently, and I asked her, "How do you want me to be a friend to you right now? You want me to just listen? Do you want me to offer you words of comfort? Do you want me to tell you the medical side of what happened? Do you want me to send you funny memes regularly from TikTok? Like, what do you want? And she told me, and I think it's similar to that, right? Understanding how people actually want to participate, or understanding what wellness means to them. Wellness to one person might be getting more steps in, and so having a step challenge at work is good for them. Wellness for another person might be having more time to eat lunch, and so making sure that everybody has a prescribed lunchtime is wellness for them. So ask, truly listen, and if it is feasible, you know, do it. If it's not hurting anybody, do the things, do the thing. But like you said, you acknowledge that it's about, sometimes it feels like, oh my God, yet another thing. And that can make people feel cynical and not buy in. And so if you give people the space to actually do it, if you can figure out in your organization, I'm sure we can, it's just, sometimes we get told we can't, but it's not really true. Um, you say, hey, we want you to participate in this thing. Well, give them 30 minutes, give them an hour a week to participate. This is your mandatory wellness time. You can either use it to participate in our, you know, existing wellness initiative, or you can use it to create wellness however you see fit. I think that's one way to sort of look at it. I'm sure there's a whole bunch others. Oh, somebody said it. I think you've got to give them the space. Exactly. You've got to give people the time and space to do it. Got to give people the time and space to do it. If it's, time is an accessibility, can create an accessibility issue. I know we think about, the very common ones, but that's one of them. If I'm overloaded, overwhelmed, I've got 10 million notes to do, and that's the only time people give me feedback is when I don't finish my notes. Well, what do you think I'm going to do? I'm just going to see patients and do notes and burn out, go home, burn out.
I love too that basically what you describe is like individualizing a plan for clinicians to support their own wellness, but also giving them the time to do that is super important. Um, One more question, and then I think we can wrap up. So could you say a little bit more about total worker health or anything else that you would emphasize that wasn't covered in the slides?
Thought you'd never ask. Okay, so let's talk about total worker health. So total worker health, it's a phrase, trademarked phrase that comes from the Centers for Disease Control, National Institute for Occupational Safety and Health. By definition, it refers to the policies, programs, and procedures that integrate sort of our traditional understanding of workplace safety from hazards, like your slips, trips, falls, chemical exposures, and more, with the newer, more modern sort of health promotion and wellness efforts in the workplace, and truly integrating them such that we advance and optimize worker well-being. Okay. And I think it is an idea that the health field can truly benefit from. We are still, we come to work, we're still workers at the end of the day. We're not exempt, right? Even though our service may look a little different. But it basically says or acknowledges that work is a social determinant of health, right? What I do for a living or not, but what I do for a living has direct effects, can have direct effects on my health. The environment I walk into, or whether it's digital or physical, it has a direct effect on my health for better or for worse, right? Work can feed your soul, it can give you the financial resources to elevate, it can be a source of social engagement. It can also make you anxious, depressed, um, expose you to hazardous chemicals and injuries on a regular basis, right? We don't want that. And so once you establish a foundation of safety, right, we need basic safety protection. Can't be walking into rooms full of gas. Um, then you can also build on and leverage the workplace as a place for increased health and well-being. Um, and what it's not, I say this, to me, it's not groundbreaking, revolutionary idea. I mean, it's the phrase itself or its beginnings maybe date back about 20 years, but the idea that you can establish a culture of health and safety for well-being in your workplace, it's been going for a few decades. And what makes this special is that NIOSH is actually funding a bunch of centers around the country, centers of excellence, some big institutional names you're familiar with, partnering with other institutions, and they are pumping out, they're walking the walk, walking the talk, I guess. They're doing the research, implementing it with um, other, throughout different industries, construction, healthcare, tech, you name it, and basically giving us the evidence base, like this is what works, so that you don't have to reinvent the wheel or guess. Some years ago, a study came out from a big name institution and said wellness initiatives at work don't work. Well, yeah, because what probably happened is that a lot of these initiatives didn't have an evidence base to them, or they didn't ask the people what they actually wanted before they did it, and then were surprised that it didn't work, right? Because maybe that wasn't a problem which you were addressing. So these institutions, they're out here just with a bunch of government funding, doing the research, partnering with your local institutions. They would love to partner with you and do some of this work in pilot programs. So that is total worker health in a nutshell.
Thank you. It was so nice to hear more about that. And it kind of reminds me of like holistic healthcare, but it's for the workers, the total worker health. Thank you for your thoughtful presentation and responses to everyone's comments and questions. I think we can wrap things up now. I don't think anyone else had raised their hand to ask a question, but that was a really incredible presentation. So thank you so much. So glad you could join us. Before we do close the webinar room, we'll open the evaluation poll to help us gather feedback on the webinar, and I will do that right now. So you should see it pop up on the right side of the screen. We'll give everyone a few minutes to complete it. And Sarah's walking us to the reference slide. You will, again, have the slides. They should be in the webinar information page and also on the webinar registration page, which we can link to again in the chat. I also wanted to link to some of the related resources that were developed for this initiative around organizational resilience, and I'll post those in the chat now too. Hopefully those pop up right. And those documents are also linked on the webinar registration page. Thank you all for attending today's webinar, and thank you to our tech support who helped make today's webinar possible. Just a quick reminder that I think I just mentioned this, the slides and documents are available on the webinar registration page. And the next webinar, Organizational Resilience, Part 3, Efficiency and Support, is Wednesday, May 10th at 2 p.m. Eastern. We encourage NHSC participants and leadership staff from NHSC approved sites to attend. Please make sure you're registered, and we hope to see you then.